if we did the reverse and said, this is about tension and I know that to be the case, and it made that assumption, and we went after it like we would a muscle that's stiff or a joint that's restricted, and we hammered away at it, we're much more likely to flare them up and increase the sensitivity while we're trying to go after this theorized restriction in mobility.
So how are you, Ben? Everything fine? How is everything?
Yeah, things are well.
California?
Things are going well. Yeah, considering all that's going on in the world, things, I can't complain.
Okay. So I know that maybe you're not used to of talking maybe here in Argentina. So maybe you wanted to introduce yourself so people can know about you and what you're doing.
Sure, yeah, happy to. And my name is Ben Boyd. I'm a physical therapist in California in the United States, and I do a variety of roles in my professional life. I do clinical work at a local academic hospital-based system at Stanford Valley Care, where I primarily see folks with persistent pain, and both in one-on-one setting and then in class setting. I also am affiliated with the NOE group, Neuro Orthopedic Institute, and teach for them. Teach things like explain pain and mobilization of the neuroimmune system and graded motor imagery. And then my third role is I am still affiliated with Samuel Merritt University in Oakland, California, where I teach as an adjunct in the physical therapy program there. But up to maybe a year ago, I had been core faculty at that university and doing research there in neurodynamics, peripheral nerve injury, pain, that kind of that arena.
Okay, so we've been talking before about different topics we can go, and some of them have been about an article you have written for my group, right? You have wrote about neurodynamics and the differences in the tests. When you test a subject, you can find that some test is normal, but that's not the way it goes, right? So in your article, you discuss about that, and you wanna talk a little about that?
Sure. Yeah, and I love it's perfect you put normal in quotes, because understanding what is normal was kind of what prompted me to take on those research projects, and it was really a series of them. But probably while I've used that word in titles of papers that I've published, more what's the common response? Particularly what was on my mind was what are we comparing to when in the clinic we try to use these tests to identify somebody with a problem within that system or pain associated with that, the neuroimmune system or the nervous system. So what are we comparing to? What is, when it's healthy, when all is well, what does that look like? And I think in various conversations with folks also doing this kind of research, there are a lot of gaps in our understanding. And I wanted to do some research in answering some of those questions of what does normal look like. So I've done a couple of studies both in the lower extremity and then upper extremity to explore a little bit of that, and for myself, but also hopefully for the field to get a little bit broader perspective of what do we expect how do we expect the nervous system to respond even when it's healthy?
Yeah. And your findings?
Yeah, of course, right? So what's really fascinating is that a couple of assumptions that I was interested in looking at, and one was when the nervous system is healthy, there'll be no response from those types of neurodynamic tests or neural tension or loading type tests. And that really isn't what we found. We found that even in people that were asymptomatic, and when we screened them for any underlying causes of or signs of nervous system involvement, and they were all cleared, they still had pretty robust responses by their nervous system in those tests, since sensory responses that could be at least partially tied to this seems to be coming from neural provocation. Muscle system responses that were amplified when we loaded the nervous system more, even in people without any pain. And range of motion changes associated with that, like the symptoms and the muscle responses that came with the loading of the test, also seemed to reduce range of motion the more we loaded the nervous system. And so that assumption that there'll be zero response from the nervous system when it's healthy was not something we found to be true. And so that makes it more challenging to compare, well, what does it look like when somebody has pain from neural irritation compared to healthy folks that have this normal classic response that still might be neurogenic, if you will, or neural provoked. And one other thing that supported that concept was the idea of doing the test and then trying to tease out, well, what was the restriction from? Was it neural involvement, or maybe it was other tissue types like stretched muscles or joints or ligaments and so forth. And the structural differentiation maneuvers that we can add to the test to try to tease that out or to weigh up one or the other, even in these folks that were healthy, asymptomatic, there was a lot of responsiveness to those structural differentiation tests or maneuvers. For instance, upper limb, we found that once you provoked some sensory response and then added either side bend towards or away, or scapular movement, like more depression or releasing depression, nearly or 90% or more had some kind of responsiveness to those tests. And that said to me that some of that restriction was coming from the nervous system, albeit that they were never saying I had pain. They were not complaining of dysfunction, and they were coming to us to participate in that study as a healthy person. That was one big assumption that a number of studies, myself included in publishing and doing them, but others as well, were really looking at. And I think that the article you mentioned, or the blog post on the NOE-Jam that you're mentioning, one of the other themes that came up through our research was the assumption of symmetry. And like, what do we expect between sides and what's normal related to that, so that we could compare, well, if in a patient they have an affected side, an injured side, and what magnitude of difference between that side and their unaffected side would be considered outside of the range of norm or outside of the range of what's common. And the more I dove into the literature in terms of symmetry of just range of motion, irregardless of whether it was neurodynamics, and then what we did in both lower limb and upper limb for neurodynamics, we were finding that, pure symmetry is actually very rare and maybe shouldn't be expected. And so some level of asymmetry is quite normal. And we need to factor that in, that influences our interpretation of, well, in somebody with pain, how much magnitude of asymmetry would be relevant.
Yeah, that's very interesting. And it's interesting because sometimes we make tests and we don't do them the same way we test things through life. Maybe we think, okay, I'm right-handed, so I am more capable of doing things with my right hand.
We expect that we have some asymmetries based on our hand dominance, but then maybe we don't carry that over into our assumptions about, well, when I'm testing a certain way for movement, factor in. I think that's what you're going after. Correct me if I'm wrong.
No, you're absolutely right. That was my point. But that's interesting. And where where does that come from? Maybe from some lack of critical thinking. I don't know. It's everybody
Well, I
lack of critical thinking. Myself,
well
testing
what
some
you
myths and other stuff. You can say, oh, let's check with the other side and let's see what's happened here. Oh, you have difference between your legs. Yeah, that's how I am. That's the way I
yeah, well, I
am.
think we should be, self-questioning when we're not doing something like confirmation bias of, oh, we found this difference and we assumed that that difference was relevant.
Yeah,
And when we did I think it was the upper limb version of that inner limb difference, or the side to side comparison, we tested the hypothesis of hand dominance for writing and which side would be more mobile on neurodynamic versus less mobile.
yeah,
And it did not tease out to actually influence people's which side was more mobile. And if we graphed out, I think we published kind of a scatter plot of this, or a line, a graph of it. There were about half people who had more mobility on their dominant side, and about half the people that had more mobility on their non-dominant side. And that, to me, challenged my assumptions of, well, I might have guessed that we're more mobile on our dominant side because we use it differently. But that didn't tease out to be the case, which was kind of fascinating. And what did make sense, though, is that in the upper limb, there was more asymmetry than what we found in the lower limb. That the magnitude of asymmetry was lower in the lower limb. And that is somewhat intuitive in retrospect to think, well, maybe we use our lower limbs more symmetrically than we do our upper limbs. We're very hand dominant, but maybe not as foot dominant in terms of use and magnitude and movement. But there's probably many other factors at play as to, well, why would we be more flexible on one side than the other? But it really did challenge. It made me rethink my assumptions about hand dominance and range of motion and flexibility.
yeah,
Some people had more mobility before they got symptoms or anything that stopped the movement in their non-dominant hand too. And so we had to look at, well, what was the absolute difference instead of the directional, like it's always not dominant is more flexible, but because sometimes non-dominant is more flexible
yeah.
or more tolerant.
Very interesting.
Yeah.
And what about other tests that you can use to test the nervous system? Are there anything? Have you tried something different since that came out? Have you been thinking about this?
You mean in terms of other things we can do to try to implicate the nervous system?
Yeah.
Yeah, I
What
mean,
your
definitely.
hypothesis about this? You may have been thinking, oh, then this compute, but not the way I was thinking. So
Yeah.
how can we test this? How can we understand what's going on? Have you been thinking about cognitive influences, behavioral influences, or things like that, or more like maybe, I don't know, more general systemic influences?
Hmm. Yeah, I mean, it's a good question, and a couple of things come to mind. The way I kind of conceptualize what we're trying to do with the neurodynamic test is to look at the mechanosensitivity of that neural immune system, that a particular pathway of the nervous system that we biomechanically think we know that we're loading in a certain way or increasing the stress to, and seeing how it responds. So kind of the mechanosensitivity of that system. There are other means of testing mechanosensitivity, like nerve palpation or
Yeah.
Tinel's compression tests that can give us a bigger picture story of how sensitive is this. Does it seem out of balance with the other side in a magnitude that makes sense for their clinical condition? And I think maybe also what you're getting at is this a very focal change, or is this a widespread system change? And when it's not so much that I have additional new tests that I might do. But if I think this is a widespread system being amplified or become sensitized, I might test not just one nerve pathway, but a couple, assuming they could tolerate that level of testing, and see, is this a widespread response, the whole limb or the whole side of the body or both sides of the body? That to me would suggest there's much more central changes going on, and the whole system is, the whole body is getting sensitized, as opposed to it's very specific to, well, it's just the median pathway, but not the radial, not the ulnar, or what have you, or not the other arm or other regions adjacent to it.
Yeah.
And that's true for the movement test, but also the palpation too. Is it focal or is it more widespread? I mean, that helps us speculate or hypothesize on, is this a local tissue change, or is this a widespread body response to whatever's going on?
I was thinking about that this is about maybe about understanding what is how pain works, but we can use neurodynamics anyway to treat patients. This is not saying anything about treatment, or is it? What do you think?
I think we should ask ourselves as providers, do we need to do something specific for, let's say, a neurodynamic based exercise or movement? Is that the best approach when neurodynamics or mechanosensitivity has been implicated? And I don't know if it always is the dominant theme of what we need to take on and try to help somebody with. I think we should consider how else can we positively affect the adaptation of the system to decrease its sensitivity. There may be other things as opposed to nerve glides or specific exercises that actually physically stress the system. There may be other approaches like temporarily reducing the stresses that it's experiencing, or removing those that don't need to be there for them to fully function, but are because of habitual posture or movement strategies or other impairments, like the adjacent tissue is irritating or adversely affecting the nerves that they live by. So habits, movement patterns, hypermobility, hypomobility that could adversely affect the nervous system. Maybe that's our go-to for some patients. And they may never need a specific, well, this is the nerve glide that's going to help you. And other people, they might need that as an aspect of their care. So I'm not sure if this is what you're getting at, but just because we find a positive or something relevant on a neurodynamic test doesn't always mean that implicates nerve glides are the thing to do. You may have many other things in the treatment approach that are more impactful. Not to disregard them as useless, because I don't think that's the case, but we should question, is it the right approach? Is it the right time or place for that with every individual?
You're saying, correct me if I try to rephrase in my own way, so I can see if I understand. So you're saying that testing through neurodynamics might say something about the nervous system, but not necessarily that means you should use it to treat patients. To check for other things. That's my addition, maybe. I think you didn't say that, but that's what I conclude after you have said.
It might tell you,
it
might help you know what's going on,
Okay.
But it doesn't always, and it by itself in isolation, it doesn't always tell you what to do about it.
Yeah.
Might help you know what's the underlying part of the issue.
Yeah.
Strategies to change that. I think we need to look broadly, including neurodynamic exercises or movements or glides, whatever you might call them. But we should look broader than just that.
Yeah. Yeah, I can imagine some cases just to, this reduction, how do you say it in English? Reduction to the absurd? Or how this this way to just putting something out so you can think about it. I was thinking about a person that says, "Oh, everything hurts." So, "Oh, this hurts. This hurts. Oh, every neurodynamic test is positive." So that's not the case. I know that's because that's why I said it was absurd. But I was thinking maybe you can find people that maybe positive just because I don't know. Maybe they think that, oh, he's testing me. This is going to say something about myself, and everybody before haven't done anything, have said, no, you're okay, you don't have any problems, are you? I have seen every image you have. So, oh yeah, this hurts. And some people may think, or maybe more predisposed in some way, just to be responders. And other people more like stoic may say, oh no, I'm hanging here, I'm hanging, I'm not going to respond to anything because I don't want anybody to know that I'm suffering. So I don't, maybe some people they may be cognitive influences on their not
Yeah,
on
I
the
think that,
response maybe, but on the decision the patient makes to say, hey, this is I think this is I think I'm feeling something here in my
yeah,
arm and in my
you know,
leg.
I think absolutely that these tests are not just tests of the peripheral nervous system and how it's protecting or responding. That if I think this is, or if I'm worried about this range of motion and going there because it hurt in the past or that's how I injured myself, it actually makes sense that that knowledge, that thought, that belief, or that understanding, or maybe even the unknown would make me protect against that range of motion even more. So it's both sensory input from the neural tissue that's being elongated here, but also the meaning of that. And that's being processed in all of what we get to interpret is rolled up into, well, we have range of motion restrictions, we have a sensory response, we have a muscle response, we have a cognitive response to it too as a patient, and it's inseparable, right? It's not the peripheral nervous system only, which maybe I didn't have that kind of broader perspective when I started even, you know, in my research here. I was like, oh, well, I'm going to focus on the peripheral nervous system. But as I got more involved and interested in pain and more of the additional influencers of this, it just opened up into, like you say, the cognitive aspect of this. What are they about to do? What did they just tell me they were going to do? I've really changed my language with this too, of it from, we're going to look at sensitivity of your nervous system to movement. To me, that sounded benign, but in retrospect, like, why don't I just say, let's look at a movement and see how, if it brings up any of your symptoms and try to make sense of where that's coming from. And that's maybe a little less threatening than, oh, you're going to test my nerves now, and I'm already on more guard. I'm already more anxious.
So that's very.
So it has different meaning, and it's you know, maybe it's because I'm a bit dim and it takes me time to learn, but it's taken me a long time to really recognize the depth of the influence of all of that. And I think that goes back to your previous question of, well, where does the intervention lie? Well, if there's a lot of worry and apprehension and fear that's coming from unknown, or the thought that I'm going to do more harm to myself, and it's cognitive and belief based, then maybe it's education and de-threatening from a kind of top-down approach. And if we tried to do a bunch of movement, that wouldn't match their understanding of what's safe. So we need to get some narrative of, actually, it is safe. This is what the body needs to adapt and become less sensitive. And then movement becomes a strategy to drive it from the bottom up, to help it learn, help it, meaning the body and how it's protecting itself. There would maybe a top down and bottom up approach. The bottom up being, well, maybe nerve glides are a good thing, but without that other narrative, maybe there's a big piece missing and it's not going to really resonate with that patient.
That's very interesting, you know. So about treating these cases where you find this response, then how do you use the language that it's nervous system, or you say no? Maybe, is it right to say that anyway?
You know,
There are other influences.
Then,
Yeah.
and that's a question I was thinking. I've been thinking for some time, and we say these are the causes and these are the modifiers. You know, why is that? If cause is a modifier and the modifier is a cause, so
Yeah.
here I think it's the same, but is the tension of the nerve causing it, or just is that enough?
Right. Well, I think it kind of brings up the point of how important the language is to express what we think is going on, but at the same time, not increase anxiety about that or increase fear and apprehension. And some of the language choices that I might make is, instead of saying, okay, well, we've identified that your nervous system is involved or your neuroimmune system is irritated or sensitized, just that the body, as it's in its role to look after you and protect you, has gotten stronger at doing so and gotten better, getting more responsive in how it's looking after you. So the bodily protection responses have increased based on what's going on in their circumstances. And the labeling the nervous system can mean a lot of different things to patients when they hear that. Okay, great, now I have nerve damage can be an interpretation that I'm conscious and cautious to try to avoid. If, you know, speaking to the piece that you were alluding to in terms of cause and modifiers, I guess I talk about different factors involved and different, what are the contextual factors that are influencing this situation. And it's a way to get the idea across without saying, well, this is what started it, or this was a consequence of it, but it's involved. So our emotional state, when we're stressed out, when we're anxious, it makes sense that that would be involved. I'm not saying it is the thing that started this process in the first place of more protection or neuroimmune sensitivity. It might have been a consequence of it, and I'm not sure I always know that I could tease that out, but I can confidently say when I think it's involved. What are the big picture kind of biopsychosocial factors at play, including what might be happening in the tissue if they've had an injury that created a lot of local inflammation or the potential for scar tissue, whatever it might be, whether it's mechanical or more kind of chemical, if you will, or physiological and not just mechanical. I think our language can be enough to understand, but also conscious of what words might increase fear or increase worry. That, oh, great, now this other system is involved. And many people get quite worried when they think that their nerves or their brain or their spinal cord or their peripheral nerves are involved. That sometimes carries a higher level threat in people's minds than, oh, it's my muscle, it's my joint. There's something about that hierarchy of, you know, the safety of that body part, if you will.
It's very interesting. So
there was one other thing, if I could just comment on one of the other phrases you used of like neural tension. And I think the way I've kind of phrased how I think about neurodynamics tests as being looking at mechanosensitivity, and tension is definitely a part of how those tests were built. Like, I mean, honestly, they were, how can we increase tension to the system or decrease it when we want to? But unfortunately, then the label of, well, it's the problem was assumed to be neural tension. And that was almost a label of diagnosis from those tests. And early on, like Bob Elvey, the upper limb tension test came from, well, we're adding tension to the system of the upper limb nervous system. And the language, I think, sometimes can influence both us as providers as well as the patient. If they start to hear that language of, well, if there's a tension problem, we must stretch it, we must mobilize it. And the way I've kind of shifted over the years to what the tests really tell us most is that it's sensitive to physical stress. It's sensitive to movement.
Yeah.
More so than it tells us, oh, there's scar tissue in this area and we need to mobilize it. And that's changed my approach of thinking about, even when mobilization or neurodynamic exercise is relevant, I'm trying to change the sensitivity of it.
Yeah.
And respect the sensitivity of it. And if there's any underlying scar tissue or mechanical restrictions, usually if we're really respectful of the sensitivity and gradually progress according to that, we'll start to remodel that connective tissue over time. If we did the reverse and said, this is about tension, and I know that to be the case, and it made that assumption, and we went after it like we would a muscle that's stiff or a joint that's restricted, and we hammered away at it, we're much more likely to flare them up and increase the sensitivity while we're trying to go after this theorized restriction in mobility. So I'm cautious about how I use the words neural tension, because I think it can be heard differently. And we might mean the same thing when we throw that term out there. I've seen a lot of patients when we start to change the narrative towards this is about a sensitized system, not a stuck system, not a restricted mobility issue system of the system. Their approach changes, their frequency of flare-ups decreases because we approach it differently, and their understanding of what the underlying problem shifts, like their paradigm shifts of what's actually going on in a what I see as a very positive way in my clinical practice.